obstructive pulmonary disease. Diagnostic, differential diagnosis of chronic obstructive pulmonary disease. Component of chronic obstructive pulmonary disease management. And you can see conclusion and literature. Definition chronic obstructive pulmonary disease according Gold. Chronic obstructive pulmonary lung disease is condition with chronic obstruction to airflow due to chronic bronchitis and emphysema, most often present in combination. In this slide, you can see Avet's definition chronic obstructive pulmonary disease according Gold. Chronic obstructive pulmonary lung disease, preventable and treatable disease, characterized by persistent respiratory symptoms and airflow restriction due to abnormalities in the airway and alveoli, usually caused by prolonged effect to harmful particles or gases and associated with internal factors, including abnormal lung development. Significant comorbidity can affect mobility and motility. Epidemiology. Over 10% of all hospital admissions. Males are more often affected than women. 20% of adult men. 9.34 per 1,000 men and 7.33 per 1,000 women, according to World Health Organization, and the age more than 40 years old. Epidemiology. According to World Health Organization, today, chronic obstructive pulmonary disease is the third leading cause of death in the world. About 3 million people die from chronic obstructive pulmonary disease every year, which is 5% of all causes of death. The main cause of death in patients with chronic obstructive pulmonary disease is the progression of the underlying disease. About 15 to 18% of chronic obstructive pulmonary disease patients die from respiratory causes. Either during exacerbation of chronic obstructive pulmonary disease or from lung tumors, up to 27%, or from other respiratory problems. Etiology: chronic obstructive pulmonary disease. Contributory factors is smoking, especially of cigarettes. Yes, pack yes equally one pack of cigarettes. Today, multiple number of yes. One pack equally 20 cigarettes. Smoking index are following: less than 100 is mild smoker, 101 to 300 is moderate smoker, and more than 100 is heavy smoker. And contributory factors are following: industrial population, industrial pollution, air pollution, recurrent lung infection, familial and genetic factors. Etiology and pathogenesis risk factor is exogenesis, Smoking, including passive smoking, the main cause of chronic obstructive pulmonary disease. Occupational danger, outdoor air pollution. Endogenosis, history of bronchial hyperreactivity and bronchial asthma, severe respiratory infection in childhood. And maybe genetic factors is congenital alpha 1 antitrypsin deficiency. Etiology and pathogenesis risk factor is ecological factors, smoking up to 90% significance, genetic factors of the activation of inflammatory cells of the respiratory system and systemic manifestation of inflammation. This leads to damage such as spasm, edema, hyposecretion, colonization of microorganisms, and immune deficiency, and maybe emphysema, fibrosis, and metaplasia of the epithelium. And all this contributes to the development of ventilation disorders, hypoxemia, and hypercapnia. In this slide, you can see of normal airways and in bronchitis. In the slide, normal bronchitis, normal bronchitis, and you can see chronic bronchitis, many mucus, and have inflammatory cellular infiltration. Chronic bronchitis is long-term inflammation, obstruction, and degeneration of the bronchi, characterized by a productive cough of sputum for over 3 months duration during 2 following years. And A for obstruction. The patient who have cough or sputum for over 3 months duration during 2 following years have chronic bronchitis. In the slide you can see inflammatory primary and secondary bronchitis. Chronic bronchitis is caused most often by exposure to ambient pollutants such as cigarette smoking. You can see change in bronchitis. Risk factor with chronic bronchitis. Smoking is first place. Exposure to second-hand smoke. Contact with a person infected with bronchitis. Viral infection of the upper respiratory tract. Cold or flu. Asthma. Chronic sinusitis. Occupational exposures to respiratory inhalants and pollutants. And large tonsils and or adenoids. Classification bronchitis are following: simple chronic bronchitis, cataractal bronchitis, chronic smoke cough, mucopurulent chronic bronchitis, obstructive chronic bronchitis, asthmatic and chronic obstructive chronic diffuse emphysematosis with airways obstruction. Attention please to all students. In the slide you can see chronic obstructive pulmonary disease. In the recommendation of Global Initiative for Chronic Obstructive Lung Disease, the classification remains based on the integral assessment of the severity of patient with chronic obstructive pulmonary disease. It takes into account not only the severity of bronchial obstruction, the degree of impaired patency, according to the results of a spirometric study, but also the chemical and the clinical data about the patient. The number of exacerbation of chronic obstructive pulmonary disease per year, and the severity of clinical symptoms according to the MMRC scale, a modified medical research council with SMEA scale, and the CAT test, chronic obstructive pulmonary disease assessment test. The patients with chronic obstructive pulmonary disease must answer the MMRC scale and CAT test. In the slide, you can see a question, modified medical research council display scale. Grade 1, degree and short of breath related to activity. Grade 1, not troubled by short the breath, expect of intensive exercises. Grade 2, short of breath when firing on level or when working up a slight hill. Grade 3 works slower than most people on the level, stops after 50 minutes, working at one pace. Grade 4, stops of breath after working 100 yards or after a few minutes of level ground. And grade 5, too short of breath to leave the house or short of breath when dressing and undressing. In the slide, you can see CAT test, chronic obstructive pulmonary disease assessment test. For example, the patient must answer the question, the situation. I never cough, and I constantly cough. I had to phlegm mucus in my lungs at all. And maybe answer, my lungs are full of phlegm. I have to feel into compression of my chest at all. And have a very strong feeling of constriction in the chest. And the patient maybe answer, 0, 1, 2, 3, 4, and 5. And maybe when I walk uphill on climb one flight of stairs, I have no shortness of breath. And when I walk up a hill or climb one flight of stairs, severe shortness of breath occurs. My daily activities within the house are not limited, and maybe my daily activities within the home are very limited. Despite my lung disease, I feel confined. And when I leave the house, because of my lung disease, I do not feel at all confident when I leave the house. Sleep very well. Maybe because of my lung disease, I sleep very badly. Have a lot of energy, and I have no energy at all. And in the slide, you can see results CAT test. From 0 to 10 points is significant impact of chronic obstructive pulmonary disease on the patient's life. From 11 to 12 points is moderate impact of chronic obstructive pulmonary disease on the patient's life. From 21 to 30 points is strong influence of chronic obstructive pulmonary disease on the patient's life. From 31 to 40 points is an extremely strong effect of chronic obstructive pulmonary disease on the patient's life. The clinical chronic obstructive pulmonary disease may be questionnaire. A clinical questionnaire of chronic obstructive pulmonary disease, CCQ, is a simple 10-item health-related quality of life questionnaire that best describes the patient's physical and emotional state of health over the past 7 days. In the slide, you can see risk classification COPD, A, B, C, D. Group A, rare exacerbation, less than 1 per year without hospitalization. Mild symptoms, CAT less than 10, CCQ, clinical COPD questionnaire less than 1, and MMRC, MMRC less than 2. Group B, re-exacerbation, severe symptoms, CAT more than 10, CCQ more than 1, MRC more than 2. Group C, frequent exacerbation, more than 2 or more than 1 hospitalization per year, and mild symptoms. And group D, frequent exacerbation and severe symptoms. Clinics COPD are following: difficulty breathing, cough that brings up yellow-green mucus, often worse in the morning, persistent and productive cough, excessive airway mucus secretion, bluish tint to lips and skin in severe cases, mild fever, mild chest pain, and swelling of the feet. Diagnostics, chronic obstructive pulmonary disease, complaints and anamnesis. The main symptoms of chronic obstructive pulmonary disease are shortness of breath on exertion, decreased exercise tolerance, and chronic cough. The severity of dyspnea is recommended to be assessed using a modifiable MRC scales. For a more comprehensive assessment of the symptoms of COPD, it is recommended to use scale. When taking anamnesis, it is recommended to assess the frequency of previous exacerbation of the chronic obstructive pulmonary disease. Diagnostic physical examination. Physical symptoms of bronchial obstruction are usually found in patients with elderly severe chronic obstructive pulmonary disease. Also, the physical examination is an important part of the overall diagnosis. It has low severity and specialty for the diagnosis of mild to moderate COPD. In the slide, you can see signs of chronic obstructive pulmonary disease. You can see finger clubbing, hypocratic nails, and purulent infection. And signs COPD, think fever, tachypnea with prolonged expiration through lips, expiration with grinding sound. Signs COPD, wound, bloating, overweight, edematous, and cyanosis. And overweight, edematous. And in the slide, you can see smoker signs. 90% COPD patients is tobacco smokers. Tar stains, nicotine is colorless, and hair discolorless. And in this slide, discolorless. Diagnostics of the chronic obstructive pulmonary disease are following. Scales A, B, C, D, PCQ test, PET test, MRC, dyspnea scale, general blood test, and biochemical blood test, sputum culture, sputum analysis for antibiotic sensitivity. Is very important for the patient. Pulmonary function test or spirometry to evaluate lung function. Pulse oximetry, 6-minute walk test, CT test, sit down, sit stand test, and alpha-1 antitrypsin test in the blood. In the slide, you can see spirometry. Instrumental diagnostic COPD are following: electrocardiography, chest computed tomography, and maybe high resolution computed tomography of the chest can be done for the differential diagnosis of COPD. High resolution computed tomography of the chest organ his recommendation to patients with COPD, with severe pulmonary emphysema, to determine the feasibility of surgical reduction of pulmonary volumes. Now you have break maybe 10 minutes, 15 minutes, please. Group leader, please send about present of students of your group.